Good afternoon, everybody. My name is Alison Campbell. I'm working with Mr. Jaffrey, who some of you may know just recently moved up to Newcastle to work with him, and it's obviously an amazing opportunity. Before I worked here, I trained in Yorkshire, and I go to paediatric surgery conferences, and I admired how Mr. Jaffrey had this massive collection of patients who he'd performed pouch surgery on, and how he's able to follow them up. And I was very impressed. The other thing that stood out for me at the conferences was people would always ask him, have you had any Crohn's transformation in your pouch patients? And that question sort of resonated with me because we did a patient in Leeds who not long after his pouch surgery had horrible fistulating disease, and on questioning ended up having mouth ulcers, and he ended up having Crohn's disease. So that question sort of resonated with me. And Bruce would always answer the question with, no, never seen it. So I've come to Newcastle and I've got access to Mr. Jaffrey's database. So quite interested. And I thought, let me have a look through this. And I was really excited to find that there's a patient who's been relabeled as Crohn's disease. So out of the 82 patients, I've found one. Let's consider him and see whether you guys think this is Crohn's disease or not. So our gentleman is now 31 years old, and he was one of the sort of first maybe 10 or so patients that Mr. Jaffrey had operated on. So he was done open. He was done 2.5 years post his diagnosis of ulcerative colitis because of failure to maintain remission. And in common with a lot of our pouch patients, they sort of sit between 65 to 75 when they come for their colectomy. He had 2-stage surgery because he was reasonably well, so it was covering ileostomy, and then about 2 months later he had closure. What we do to form the pouch is first you mobilise the colon, take the colon out, do the endo-anal dissection, so down into the so first it's submucosal, and then it's close on the rectal wall to get the rectum out. And we do quite a low anastomosis. And Mr. Jaffrey always does a hand-sewn anastomosis because staplers in a kid's pelvis just really don't go. And this guy did really well post-operatively. Initially, his pouch function was very good. He was going 3 times a day. And, because a lot of our patients can go up to 8 times a day. So he was doing really well. He's had 1 episode of pouchitis during follow-up. But then comes the punchline. He's been extensively investigated for weight loss, fatigue, and abdominal bloating. From a gastroenterology and surgery point of view, his last pouchoscopy 2 years ago looks completely normal. He's even had an MRI intragram that is completely normal. So far, really, are we really considering this as Crohn's disease? There's quite a lot of background. This young man, even before he came for pouch surgery, was suffering from depression and had been episodes of self-harm. He's been investigated for hypermobility and has been given a label of query Ehlers-Danlos. He's had palpitations and chest pain and been diagnosed as having postural orthostatic tachycardia. He's currently seeing a private anaesthetist in Bristol for injections for pain, and he's got a diagnosis of anterior cutaneous nerve syndrome. He's then gone to gastroenterology at St Mark's in London for investigation for small bowel neuropathy. And where's this label of Crohn's come from? Well, actually, it's his last respiratory clinic letter. They've written Crohn's on the letter that's going out to the GP. But this isn't based on any new histology or any stricturing disease or any fistulizing disease. So actually, I'm a bit less excited for the fact that I've managed to find a Crohn's transformation in Bruce's subset of pouch patients, because I'm not sure that this is Crohn's. So what would I consider would be worth you could change the diagnosis to Crohn's if in a patient with ulcerative colitis previously. I think if you get inflammation of the pouch or afferent limb that's resistant to antibiotics, consider it. Stricturing disease that is not related to post-op stricture. It's new stricturing, or fistulizing disease involving perineum or small bowel, or pre-pouch ileitis. These things, if you see them or a patient's got them clinically, you would consider changing the diagnosis to Crohn's. And histology, obviously, fistulous tracts, granulomas, and apparently pyloric gland metaplasia can be fairly diagnostic of Crohn's. I'm not sure that having weight loss and abdominal distension and normal pouchoscopy and a normal MR enterogram really constitutes Crohn's, so I don't think our patient has that. So, for those of us, including me, that were not until a few months ago much involved in looking after large numbers of inflammatory bowel disease patients, what's the real outcome for pouches? What percentage of people end up having transformation and change in the diagnosis or phenotype flip to Crohn's disease? And looking at different series, it's somewhere between 3% and 25%. Patients. Recent meta-analysis suggested 10% of those undergoing restorative prostatectomy for ulcerative colitis would develop Crohn's. In the National Pouch Registry, their sort of 2017 publication, 5% of pouches that failed, it was due to the patient developing Crohn's following their pouch. So therefore I thought, would a pre-pouch diagnosis of indeterminate colitis, where we're not sure what is it, would that make things more likely to turn into Crohn's disease post-pouch? Well, according to a paper from Jackson et al. 2016, actually, it doesn't. The rate of transformation
You're on, Dan.
and then go to share my screen. Have you got me back?
Yeah, we can see you.
And can you see my slides now?
Yeah, we can.
Perfect, thank you. Sorry about that. So yeah, I thought it's really odd. Why would Bruce's pouch series, which is children, be doing better? Because younger age has been shown to be a risk factor when you look at any adult series. So I looked at some specific paediatric series. So we've got a Japanese series, 212 paediatric ulcerative colitis patients. They're called paediatric because they were under 17 at the time of surgery. The follow-up's not massive, but none of them had their diagnosis changed to Crohn's. However, unlike in our series, 3 were on biologics because of features suggestive of Crohn's. So although they've not been labelled as it, they potentially are Crohn's. However, at the other end of the spectrum, an American paper with really good long-term follow-up, only 74 patients, again, surgery at a median age of 18, but diagnosed as children with a follow-up of even up to 20 years, 28% of them converted to Crohn's during long-term follow-up. However, interesting, the majority of the change in diagnosis occurs by 5 years post-op, and very few cases occur after 10 years. So perhaps being paediatric isn't the risk factor that I thought it ought to be, and that maybe fits with what we're seeing here in Newcastle. I then wondered, well, why does this happen? Why does something that why does one disease that's supposed to have skip lesions and at different levels of the bowel and all the rest of it. Why would that develop in somebody who's got ulcerative colitis? Is it the very fact that they have a pouch ano anastomosis that makes it more likely to happen? Is it something to do with what they change, their dietary change, smoking, lifestyle habits that happens over a lifetime? Or is it something just that we've not actually labelled it correctly, indeterminate colitis being labelled as ulcerative colitis? Well, obviously looked at the paper Jackson et al. 2016 that suggests that actually indeterminate colitis isn't a risk factor for phenotype flip, although that they're not the only. There are papers that suggest otherwise. Why might we not see this in Newcastle? What's so special about Newcastle? Well, I think I'd like to blame the gastroenterology department and the pathologists. So obviously our gastroenterology department must be pretty good. What I have noticed is that they seem to scope the patients quite a few times before they're getting referred for pouch surgery. So I guess potentially making sure that the diagnosis is confirmed before they're handing them over for surgery. Perhaps it's the pathologist willing to make a firm diagnosis. I need to look through our histopathology and see how often are they labelling somebody as indeterminate colitis, or is it because they're willing to come down and make a firm diagnosis? Or is it something like the microbiome? Is it because people don't move around a lot potentially in this part of the country, and so diet and lifestyle maybe doesn't change as much? So perhaps that's another reason why people aren't developing Crohn's disease, having been previously diagnosed with ulcerative colitis. Does it matter? Well, according to most series, 50% of those who have the phenotype flip and develop Crohn's disease will lose their pouch. But otherwise, for most series, 10-year pouch survival is in the region of 90%. So I guess it does matter. We do know that if you develop fistulizing disease rather than stricturing disease or your pre-pouch ileitis, you're more likely to end up losing your pouch. What I found really interesting is that we do pouch surgery for people with colonic Crohn's disease. So if they've only isolated colonic Crohn's disease, they can end up having pouch surgery. And for those patients, their pouch survives far better than for somebody who has a Crohn's diagnosis made when the colon is removed before the pouch is formed. And these patients do better in keeping their pouches than those who are diagnosed during the pouch follow-up. So that's interesting, but I'm not sure that it massively helps us. So what I'd like to do, seeing as I seem to have raised a lot of questions rather than answers, is I'd like to look at our pouch series. I'm going to get in touch with the adult general surgeons that are now following up a lot of our patients that are not the ones that are not here in Newcastle, and see, have they genuinely not changed their diagnosis? And then my theory about the gastroenterology workup being excellent here. We'll see if that's what it's about. I'll look at how many colonoscopies people have had before being referred for colectomy in consideration of pouch. And then perhaps it's the pathologist. So I want to look through all our histopathology and see was there any change in diagnosis between specimens before they eventually came to having their pouch surgery. So I'm very happy to take any questions.
Thank you. Right, so we'll open this up. Good. You want to start?
So if people have a question, if they could, would it be easiest maybe to kind of switch the camera on so we can see them, and then we to try to prevent people from asking the same? Would that be possible?
Yes, so thank you for that. I'm not a gastroenterologist. However, what lessons do you think this has for other specialties? Because I suppose what you're saying is that maybe it's not a misdiagnosis, but the disease change throughout life, and then they go from children to adult services.
So I think, first of all, I'll go for the lessons specifically related to pouches, which is obviously quite specific. And then the sort of bigger picture, if we look at this patient that I have presented and the sort of like rather odd label. So with regard to pouches, you need long-term follow-up. You need to know who your surgeon is, and yeah, you need long-term follow-up. There's not any way out of this. So while for lots of people getting rid of their colon for ulcerative colitis is they think, okay, that's it, the cancer risk gone, all the rest of it. But the problem is your pouch can develop problems in the long run. So you need to know who your pouch surgeon is. So when you transition from paediatric to adult services, that's really important. And so that's the sort of niche lesson for pouches, which is obviously a very small area of most people's practice. I think the lesson from this case, so there's me all excited. Look, I've found one. Bruce says that he's never had anybody converted to Crohn's diagnosis. Look, I found this patient with the Crohn's diagnosis. It's really interesting that what I expect happened was the patient told the respiratory consultant, I've been to St Mark's in London or somewhere, and they've said I've got Crohn's disease. So we've got no new histology. We've not got any evidence. We've got a normal pouchoscopy. We've got a normal MR enterogram. But yet we've changed this patient's label to Crohn's disease. And anybody receiving that letter and who reads it, because it's a nice clear letter, will think, oh, this patient's now got Crohn's disease. So it's just an important lesson, I guess, when reading letters or when looking through patients' notes to, just think a bit more when there's not really very good evidence.
Natasha, your webcam is on. Do you want to ask a question?
Yeah, so if there's a difference between people who have a pouch for Crohn's and the pouch survival in people that have had it for UC, is it because they're presenting with pouch failure, or is there a difference in management of the pouch between the two groups? And could closer follow-up improve pouch survival?
I'm not entirely sure why. Because now our pouch for Crohn's numbers here in Newcastle are really small. We colitis, and one of the pouch for Crohn's has ended up have given up on their pouch, so about just slightly 11%. So slightly later versus it being picked up in long-term follow-up. I'm not entirely sure. I think that's something really interesting. I would like to look at it.
So, Alison, you're saying that so these are both inflammatory bowel diseases. So you've described a case where potentially you have a transformation from ulcerative colitis to Crohn's, but to clarify, it also happens the other way around. So you also have patients who have Crohn's who then transform to ulcerative colitis, or is that not a pathway?
That's not a pathway that I've seen, but I guess that's because I've not done a lot of inflammatory bowel disease stuff. I've only been working with Bruce for 2 months, so please do not take me as an expert on anything. I'm fortunate enough to be up here and learning from Bruce, and it's a really good opportunity. But what I have to say in my experience is that you do sometimes see people who are initially labelled as indeterminate colitis, and then as time goes on, pathologists are able to make a more firm diagnosis, or there's better histopathology, and so they become labelled as ulcerative colitis. And I think even in our series, although I've only just started looking at the old histopathology, there's a couple that may have been indeterminate colitis initially, that were later labelled as ulcerative colitis. But yeah, I haven't seen the other way around, but that's probably because that doesn't often get referred to the paediatric surgeon. That would be, I guess, something that can happen more later on in life.
Thank you. And so if your hypothesis is correct that within the trust, the gastroenterologists and histopathologists are on point in order to give you the right diagnosis, does that mean that the incidence of indeterminate inflammatory bowel disease in the trust is lower than you would expect in other places?
As I haven't looked at the indeterminate colitis population, I can't say that. I guess that is a hectic project, and perhaps maybe I should consider taking that on. If I get on really well with the looking at all the ulcerative colitis pouch data, then I could consider looking at all the indeterminate colitis. But yeah, thanks.
All right, are there any more questions from the audience? No, I see no cameras flashing up, so I'd like to thank you all for attending, and thank you, Alison, for the presentation. Please look out for emails. We have sent a program which will cover most of October, September and October, so please attend in greater numbers our meetings going forward. Thank you so much.